Well, I'm Dr. Abro. I'm one of the staff here in the nephrology section. And I'm here to present a topic that it's exciting for us. Hopefully it's exciting for you guys as well. It's about IgA nephropathy, and so I'm just going to first kind of give you a little bit of history about this disorder. It was originally called Buerger's disease. It was first described in 1968. The Crown Prince Joseph Habsburg in Austrian-Hungarian Empire in 1801 had IgA in his kidneys. The reason why we know that is that his kidney was stored, so they were able to look at it 200 years later. And it was known that he had IgA nephropathy there. So that was one of the earliest cases that we know. And what the disorder is, primarily it's an immune complex mediated glomerulonephritis. And it's generally more common around the world than I would say, than the US. I mean, US we don't see, you can say a lot of cases, but if you go around the world, especially in Asia and Japan and so forth, it's more prevalent there. And IgA is the main cause of ESRD in patients with primary glomerular disease, which require renal replacement therapy. And you can see the disease associated with IgA is the primary causes, that's what I'm going to talk about, is IgA nephropathy. I'll touch on the Schönlein-Henoch purpura, which is a variant of IgA nephropathy, and I'll go into that a little later. And then you have all these secondary causes. You have IgA deposition in the kidney due to various causes. I have a laundry list of here, such as liver disease, you can say intestinal disease like celiac and Crohn's, and skin disorders, and some of the malignancies and so forth. So you can have IgA deposits. Doesn't necessarily mean that they have primary, but usually they have secondary causes. And it can occur at any age, and usually occurs in the second and the third decade of life. It's seen more in males than females, and I mentioned that to you earlier, that we see it more in the Asian, whites and Asian population. So if you have a patient, so that's the one thing that you have to kind of look at when you're seeing a patient. This is what you would kind of consider, that these are the most people that are more prevalent in terms of getting IgA nephropathy. African Americans are a little bit less, and so forth. And the prevalence, I think the main geographical area I just put here is Singapore, Japan, Hong Kong. They have, and some of the European areas, Finland, Southern Europe, they carry about 20 to 40% in terms of prevalence. In the U.S. is not as much, 2 to 10%. But however, if you have, if you live in the area like New Mexico, they have Native Americans there. You see it a lot more with those patients. The prevalence rate goes up to 38%. And the etiology is not really well understood on what the exact cause is. You get this development of this gross, hematuria immediately after an episode of upper respiratory tract infection. So they were always thinking that maybe it's a viral related disease. They always, this was a setting that sometimes they saw it in. So they thought maybe it was a virus or bacteria that was causing IgA nephropathy, but they weren't really able to isolate anything. There has been no links between hypersensitivity to food either. So, and then they also saw that patients who have strep or staph infections kind of resemble primary IgA nephropathy. When you look at it, so they thought maybe the bacteria that they're looking for is possibly strep or staph. However, it's a separate entity. The post-infectious IgA dominant GN is separate from primary IgA. So, and this tends to be seen more with women who are diabetics, who rapidly have a progressive renal disease and who have nephrotic range proteinuria and so forth. So, and they tend to develop this staph and strep infection, and they go into this kind of resembling IgA nephropathy, but it's not the exact entity. And there are immunological factors that predispose patients to IgA nephropathy. There have been some studies that are looking at HLA antigens. Some of the antigens may be as a predisposition. Genetic analysis of IgA nephropathy is the most promising. So they're thinking likely is a genetic link to this entity itself. And what happens in this pathogenesis is that we produce these IgA. We produce it in our upper respiratory tract here and GI tract. We produce IgA1, IgA2, primarily the GI and the upper respiratory tract produce both IgA1 and IgA2, whereas the plasma cells in bone marrow produce IgA1. And the glomerular deposition in IgA nephropathy is mainly IgA1 subclass, and I'll tell you what happens in these patients. So increasing production of IgA is not really sufficient, for IgA nephropathy. There's something wrong with these IgA1 molecules, which I'll go into in the next slides, that kind of causes the nephropathy. So if you have a patient who have elevated IgA levels, doesn't necessarily mean that they're going to develop IgA nephropathy, okay? And we've seen that with patients who have these, these myelomas secreting, secreting a large amount of IgA, but then they never really see IgA nephropathy. You never see that renal involvement. So studies have now focused more into the abnormality of the IgA molecule. And IgA1, like other immunoglobulins, is heavily glycosylated with these sugars attached to the protein. You have these N-linked sugars that are complex structures linked to asparagine or residues and so forth. And O-linked sugars consist of simple sugars. And I have an illustration here. Here's your IgA molecule. Here's their hinge region, and you have these, and you have the old. This is the old link that they're describing here. You have the IgA presence on the. So you have the IgA in the presence of multiple O glycosylation site with the hinge region. So this is what the abnormality is. That this area is underglycosylated. And because of the underglycosylation hinge region, it causes like an aggregation. This is poorly cleared in the kidney, and it binds to IgG, and it binds to fibronectin and activates complement. So that's what happens. And this is an illustration on how different forms you can have the monomeric and the dimeric, and then the polymeric, and so forth. And these are the aggregates that form, and the IgA. So this abnormal, or the IgA1 has this. The underglycosylated has a very high affinity to the mesangial cell, which is located in the kidney. Mesangial cell possesses this receptor, the IgA1, and which causes this immune complex glomerular inflammation. And I have a nice illustration that kind of illustrates that better. You have this circulating IgA1. Remember, this is underglycosylated molecule, and then the mesangium has this receptor to it, and it's a high affinity to it. And once it binds with that receptor, it causes these pro-inflammatory mediators that form, and you get this mesangial proliferation, podocyte damage. And some of them, and you get this extracellular matrix synthesis as well. And then some of these complexes get filtered into the urine, and you have the proximal tubular damage as well that you see. And then, so that's a typical feature with IgA nephropathy. You look at, when you do a biopsy on these patients, when you look at a light immunofluorescence and EM, that's what you would see. And I have some illustrations that show this. And you can see right here, here's a light microscopy. You can see the mesangial expansion here. You see how densely pink and reddish it is right here. That tells you that the patient has mesangial expansion. Plus you see the tubular atrophy and tubular damage as well. So this is how the pathophysiology of how this entity occurs. And here's the immunofluorescence. You can see how densely it's basically, you see the very dense deposits here of IgA. And then if you look at the EM, you have the dense deposit here in the mesangial matrix. I have a little arrow that kind of illustrates that dense deposit. So that's what you see. So you do have glomerular damage. That's why you see protein in the urine, and also you see RBCs in the urine because you also have the basement membrane also being affected. The clinical feature is usually variable, and it ranges from asymptomatic hematuria to rapidly progressive GN. So you can have a patient who's asymptomatic and he has some blood in his urine and it resolves with time, and then they do okay. And then you have others who rapidly progress really fast, and they sometimes some of them may even go into end-stage renal disease. So you have to kind of be you have to kind of follow these patients pretty closely. And this is the clinical features here, 40 to 50% of them usually present with one or a recurrent episode of this gross hematuria, usually following like an upper respiratory tract infection. 30 to 40% have microscopic hematuria, usually mild proteinuria, and usually is incidentally detected. Less than 10% present with either nephrotic syndrome and acute. So there's in terms of IgA nephropathy, I would say majority of the cases are, they don't really, some of them, they present with hematuria, then they resolve and they do fine. Other ones, sometimes the hematuria doesn't resolve, so you have to treat them. Some of them actually progress really rapidly, so you have to kind of, and they all kind of fall into this little range. And 15 to 40% present patients who eventually go into ESRD. The episodic macroscopic hematuria is most frequently in children, associated, like I said before, due to upper respiratory tract infection or GI infection. You can have nephrotic syndrome or hypertension, which is usually uncommon. Then you have the asymptomatic hematuria and proteinuria patients, patients who have persistent microscopic hematuria, hypertension, impairment of renal dysfunction, and so forth. And I'll tell you why that's important. When we do and when you have these patients, we usually tend to biopsy these patients. And when the pathologist looks at these patients, they give you or you can do it on your own. You can do like an Oxford Met score, in which it kind of tells you how bad the pathologic parameters are. And you can see if, like, this is a rating scale for these patients. When they see mesangial hypercellularity, they give it a 1 score. If you see intercapillary hypercellularity, they also 1. So, and then segmental sclerosis, tubular atrophy. So if you have like patients who have all the above, you'll get a maximum score of 4, and that kind of tells you how advanced their disease is and how aggressive you should be in management. So this is a very good tool for us to know how severe the case is going to be and how aggressive we should be in managing these patients. So diagnosis, the gold standard obviously is renal biopsy. However, you can do a UA. You will see on a UA you'll see RBCs. You'll have if you do a protein to creatinine ratio and so forth, you usually have a greater than 0.3 grams per deciliter proteinuria. In Japan, they also have used these serological markers. What they've done is they look at the level of the IgA compared to IgA over C3 ratio. If it's above 3, there's a higher incidence that the patient has IgA. So these are some of the serological studies that we don't really use this here in the US as often, but it is used over there in Japan. Elevated IgA levels. Like I told you, this is not really a good serology because there can be other disease processes that you have elevated IgA levels. It doesn't necessarily mean that they have IgA nephropathy. So these are all the serological studies that we do. We also look at their renal function as well and so forth. But for the ultimate and gold standard is a renal biopsy, and that's how we diagnose them with the IgA nephropathy. And there have been developing this, we have been trying to develop biomarkers, not only for AKI, but also some of the GNs that we deal with. And they've been looking at the CXCL1, which is found in the mesangium. And whenever there's a mesangial injury, they see this in the urine. So they're trying to, this was published in 2015, just recently, this biomarker that they're looking at. And they're saying that this actually can help us with at least as a prognostic value, and can actually be used as one of the serological markers we can use. So hopefully This has not been validated yet, but this is some of the things that they're looking at as a potential biomarker. So the things that cause, or things that we look at that kind of tells you that patient has progression or you can say poor renal survival. If the patient has, hypertension with a systolic greater than 140, if they have this high histopathological score that I went over with you, the Oxford Met score, or if they have persistent microscopic hematuria, proteinuria greater than 1 gram, for greater than 6 months, or if you have renal impairment, all these things kind of tell you that this patient is likely going to progress and is going to have a poor survival if you don't intervene. And they also have looked at, this was a study in Japan that they looked at around 2,000 patients, and they kind of looked at the incidence of ESRD, and they saw that patients with a serum creatinine level less than 1.25 at the time of diagnosis, their progression is to ESRD is only 2%, 2.5%. If you have a creatinine between 1.2 to 1.6, you have a 26% chance of progressing into ESRD. If you have a creatinine of 1.68, 71%. So you can see that serum creatinine actually kind of gives you a really good prognostic value of these patients. If you have a patient on the time of diagnosis, if they have a very elevated high creatinine level, those patients have probably a worse prognosis, and those are the ones that we, as a nephrologist, treat very aggressively and try to prevent this from occurring in terms of at least, delay the progression. And the treatment, there's and I'm going to go through the treatment section pretty extensively here. But we have been using ACE inhibitors, steroids, and I have other medications to go over too, as also fish oil, as well as another treatment option as well. And I'll go over all these treatment options and see which ones are the best ones out there for, and it really depends on their, and I'll go over that a little later as well. It depends on their presentation as well. So ACE inhibitors have been, you can say, a benchmark or a hallmark for our treatment of IgA nephropathy. Both observational studies and randomized controlled trials have suggested evidence that ACE inhibitors or ARBs are more efficacious than other agents. So those are our first line therapy with these patients. And they have shown that there have been a slow decline in progression of the disease process and the drop in the GFR. And you can see here's a study that kind of illustrates that. These patients, there are about 32 in the ACE group, and they had a placebo, about 34 of them. And they kind of follow these patients over 60 months, and you can see the patients with who were on the ACE inhibitor had a better renal survival compared to the ones that are on placebo. And also meta-analysis that have kind of combined all these randomized control trials, because these trials, again, you have to understand they're very small. So what they did is they kind of this particular one, they just kind of combined all those randomized control trials, and they came up with 585 patients, and they saw that ACE inhibitors have shown reduction in proteinuria and preserved renal function. ARB have also been looked at as well, and I just pulled a study from 2009, and they actually showed that ARB at a higher dose had a better benefit. They had like 4 arms. They had about 200 patients. There was a randomized control trial. They had one arm that had high dose losartan. They were giving those patients 200 milligrams a day, and then the normal dose was 100. You had another arm that had they were using enalapril at 20, and the fourth arm was the one that was using 10 milligrams. And they found that the high dose ARB was the most efficacious in reducing proteinuria and slowing. So, and this is just one trial that they were just saying there was a ARB kind of performed a little bit better than ACE, but in general, either or are, and these are our guidelines that we follow, are KDIGO, which is the Kidney Disease Improving Global Outcomes. These are the ones that we actually follow, and then what they do is they look at these clinical trials and they come up with these recommendations, and that's what nephrologists follow. So after reviewing all the literature and everything, they do recommend that you use ACE or ARB treatment when proteinuria is greater than 1 gram. And they do suggest, and you can see the evidence is pretty decent there, 1B. We suggest that ACE or ARB should be titrated, to achieve the proteinuria less than 1 gram. And then the target blood pressure should be less than 130/80. So that's the recommendation that you follow. And both ACE and ARBs are the mainstay for therapy. Steroids also have been used for over 20 years in treatment of IgA nephropathy because it has this anti-inflammatory effects. And here's a study that was published in 2004 in JASN. They actually had patients they were giving actually pulse steroids at month 1, 3, and 5. They were giving 1 gram of IV Salimedrol times 3 days. And these patients were also on this oral prednisone at 0.5 milligrams per kilogram every other day for 6 months. And they found that patients who were given these corticosteroid therapy actually had a renal survival without doubling of serum creatinine. So they did see that steroids did actually improve renal survival in these patients. And also meta-analysis also are suggestive that the corticosteroids was effective in reducing proteinuria and preserving renal function. The ones that didn't really respond to the steroids were the ones who were very advanced, who have very advanced glomerulosclerosis, interstitial fibrosis, or advanced or elevated, really high elevated creatinine levels. They already had, you can say their damage was already done. So it's very, so the steroids weren't really able to help those guys. And then that's what we suggest. That's why the biopsies becomes very important. So if you have a patient with, if you do a biopsy on these patients that has, proteinuria and hematuria and also elevated creatinine, if we see that the biopsy is showing severe interstitial fibrosis and very advanced disease, we're probably not going to give them IV steroids or give them any steroids in general because they're not really going to respond because the damage has already been done, unfortunately. So they have looked at patients. So obviously ACE and steroids are, the mainstay therapy. So what they did is they actually placed patients on combined therapy with ACE and steroids together. And then they found that, they wanted to see how, what the outcome was. Did the kidney function improve? Did the proteinuria decrease? Or how was the renal survival? And so this was a study that was published in 2009. They had 63 of these Chinese patients who were randomly assigned to these ACE alone or ACE plus steroid. And they looked at the urine protein excretion, and they found that the patients who were on the combination therapy had less proteinuria compared to the placebo, for example. I'm sorry, not placebo. Sorry, ACE alone. So you can see the ACE and the steroid. ACE and steroid combination. You had 1 gram proteinuria. The other arm that had ACE alone had 1.5. So after 4-year follow-up, 24% of the patients ACE alone group developed development of a 50% rise in creatinine versus 3% with the steroid and the ACE. So steroid and ACE group actually perform much better in that setting. And this is a study that kind of illustrates that the patients who were on the ACE and the steroid therapy actually did better than the ones that were on ACE alone. And they actually, all these studies actually were looking at patients with a protein greater than 1 gram in 24 hours, and they actually had pretty decent kidney function. They had a GFR greater than 50 mLs. They haven't, so that's why then the KDIGO came out with these guidelines that, yes, that they did suggest that patients with persistent proteinuria greater than 1 gram per deciliter, if you have a patient that you have placed them on ACE inhibitor, you've been following them for about 3 to 6 months, and they haven't really improved in terms of their proteinuria just with ACE alone, then you should try steroids as well. And they were saying that with the GFR greater than 50 mLs per minute actually is recommended for these patients. And then we actually said, okay, what about the patients who don't that have actually less than, what if those patients that have less than 50 mLs per minute? What about those patients? Do they benefit from ACE and steroid combination or not? And then this actually came out in February of this year. They actually did a retrospective. This was a retrospective analysis of the VALIGA study. which was a European study that had about 1,100 patients. What they did is they did a propensity score. They matched about 184 subjects who received steroid and ARB, 294 with a similar risk to progression only. So they had 184 patients they were on steroids and ACE and ACE, and then they had the other ones on ACE alone, and they found that patients they saw the same thing, that you had decreasing in proteinuria and then increasing in renal survival. However, they also said that these benefits extend to those patients who even have a GFR less than 50. So they were saying that from this criteria that I just mentioned, they were saying that even patients who have a lower GFR, they actually also benefited from ACE and steroid combination as well. So, so that's why I think this guideline was published in 2012. I think they're going to probably update this likely on the next, whenever the next guideline comes out. They'll probably update this to also to reflect the lower GFR patients as well, just from this study. And fish oil also has been used. There have been actually multiple trials that have looked at it, and they have shown some benefit. You can say not like a huge, not a huge benefit, but there was a minor benefit, and so that's why we. In the clinic, when patients are placed on ACE inhibitors, we actually give them an option of also putting them on fish oil as well, if they're able to tolerate it, because there have been studies that have shown some benefit with fish oil, because it has this anti-inflammatory properties, so that's why we consider it on these patients. And I just pulled a study that was done in 1999 here. You can see that patients who were given fish oil actually had better survival, renal survival, compared to those who were just on placebo. So we do suggest that fish oil can be used for patients, who have persistent proteinuria and so forth, in combination with ACE inhibitors. So you should not use fish oil as a monotherapy. You should always use fish oil with ACE inhibitors, so as a combination. They have looked at other drugs like MMF, which is mycophenolate. Hasn't really panned out too well. I think they still haven't done a lot of large randomized control trials, so I think the jury's still out on the MMF drug as a benefit, but so far it has not been that successful in treatment of IgA nephropathy. They have looked at patients who they have looked at cyclophosphamide combination. They have placed patients on steroids, combination with cyclophosphamide, and this was a study that was published in 2007. They actually showed that there was benefit in actually a combination therapy. And I think for us, what we do is that we don't really go to cyclophosphamide right away. You reserve it for patients who have like rapidly progressive renal disease, or usually crescentic. If they have a crescentic pattern GN, for example, on the kidney biopsy, then we actually do consider the heavy gun, which is cyclophosphamide with steroid therapy. That's not the first line of choice, but patients who have crescentic GN pattern on their biopsy, usually greater than 50%, and they have rapidly progressive kidney failure, those are the ones that we usually would consider doing steroid with cyclophosphamide. And that's what I'm just kind of illustrating that that this was a study that was published in 2007 that kind of looked at these group, and actually they did show renal survival in these patients who were on this steroid and cyclophosphamide group. So that's why the KDICO came out with this guideline. So they were kind of telling you that kind of reserve this cyclophosphamide and steroid therapy for the patients who have the GN, which I kind of told you before. We reserve that for them, and it's not really one of those things that we do for patients who are mild disease and so forth. It's not really our first line, but that's why the biopsy, I was going to keep kind of saying the same thing, but the biopsy is really, really important for the management of these patients. Biopsy along with their clinical picture, how advanced their kidney disease is. They're looking at their serum creatinine, how advanced is their proteinuria, and how persistent is their hematuria. So clinical picture is a way that we treat these patients. They have also looked at tonsillectomies, and I just kind of pulled this article here that actually looked at there was a benefit of doing tonsillectomies, but actually that was not really proven with large trials. You can see that this trial only had about 33 patients, 33 in group A, which was a tonsillectomy group, and the other one was the 39 in the placebo arm. So these are not really large trials that they have looked at. But I think when I was reviewing the literature on tonsillectomy for treatment for IgA nephropathy, they were mainly saying that if you have patients with tonsillitis or repeat infections in their adenoids and so forth, and they keep getting, these infections, and they keep going into this issue of getting hematuria and proteinuria. So those are the patients that you should maybe consider doing a tonsillectomy. Those are the ones that benefit the most. But if you have patients who don't have those symptoms, it's really no point of you doing a tonsillectomy on those patients. So I would say that subclass it may be benefit. That's why I kind of put that as a controversial treatment. So tonsillectomy, I would say for those patients you can consider it, but it's not really a mainstay treatment for IgA. MMF, I kind of told you that the jury's still out on that one. Calcineurin inhibitors, they've actually looked at high-dose IVIG. So all of these other things that I'm just kind of telling you here, they're still controversial. There hasn't been really large randomized control trials that kind of tell us that these are efficacious in treatment for it. Renal transplant is the best option for the patients who progress into pretty advanced kidney disease and end up on dialysis. Kidney transplant is the way to go for these patients, and they do really well. And on one report in the U.S., the IgA nephropathy accounts for about 10% of renal transplant among patients with primary glomerulonephritis. In Europe, it accounts for 7 to 20%. And this is not a contraindication. If you have a patient with IgA nephropathy who progress into end stage, for example, we don't necessarily decline them a kidney transplant. I think kidney transplant, they do really well because usually they are on, post-transplant, they're on steroids and immunosuppression therapy, so they do really well. And then we have seen that as well. You can see that IgA nephropathy can reoccur up to 75 to 80% in the donor kidneys. However, the decline in renal function and graft loss is only less than 5%. So yes, we do see reoccurrence, but the kidneys do well post-transplant. And the people who have a high risk of reoccurrence, patients who, when we're looking at them from the transplant perspective, when we get these young patients who've had this disease when they were very young, they will know that these patients are likely more susceptible to getting recurrent IgA nephropathy, or if they had a short course of disease to onset of ESRD, usually less than 5 years, if they have crescentic pattern on the renal biopsy, living-related or zero-match kidney, and all these things that actually predispose them from, and they carry a high risk. So when we are looking at these patients from a transplant perspective, if they kind of meet all these criteria, those are the ones that we actually really closely monitor post-transplant, and we usually kind of keep their immunosuppression a little bit on the higher side because we know that they may have they are at high risk of recurrent IgA. But like I said before, when we do when we see these patients closely and follow them in the clinic, they do pretty well, even if they have these high risk factors. And it doesn't really matter if they get cadaveric or living kidneys. So let's say if a relative gives them a kidney, the recurrence rate is the same as a person, or the deceased donor, for example. So cadaveric and living donor really doesn't make a difference in terms of recurrence IgA. It's about the same in both. So that's why we don't really discourage living donors either. And this is I just wanted to touch on this entity, the Schönlein-Henoch Purpura entity, which is kind of I would say like a variant of IgA nephropathy. If you do a biopsy on these patients and and you look at it as a pathologist, they're basically identical in terms of at least the renal manifestation. So we kind of looked at this entity as a variant, you can say, and you know that this entity it's a vasculitis that affects your small vessels, your capillaries and venules, and typically involves the skin, gut, and glomuli. And it peaks in the first 2 decades of life, and you can see that usually you have a triad of these things. You have this this rash that develops, an arthralgia, abdominal pain. This is usually the symptom that the patient has, and you can see that they usually have a acute onset and self-limited, and some of them progress into renal failure. So although the clinical manifestations are distinct, but you can say the histopathological are very, very, very similar. And you can see this rash here that is kind of, and you can see this is like the classic rash that they always describe with these patients. And when you look at, when you do a biopsy of their skin, for example, you see these IgA deposits. And like the deposits of IgA nephropathy, the glomerular deposits in this vasculitis consists exclusively of IgA1, and the serum IgA1 is isolated in these patients, have the same entity. Remember that pathophysiology I was describing to you, that this underglycosylated IgA1 is also found in these patients as well, and then leads to the same pattern of injury in the kidney. And on that basis, they have looked at actually identical twins. One has IgA nephropathy, the other one has the vasculitis. So they're saying that they're saying that maybe there's an environmental factor or something that kind of predisposes the patient from going from one direction to the other. We still haven't really found what that is, what that factor is, and there have been saying that a lot of observational studies actually support the notion that IgA along with this vasculitis are variants of the same pathological process. So that's why I think the genetics of this entity is the most exciting, and hopefully we'll be able to find out the exact, maybe we can figure out what the environmental factors are that kind of predisposes the patients to this. So in summary, patients with isolated hematuria or minimal proteinuria less than 500 to 1,000 milligram per deciliter with normal GFR. They usually, if we have a patient with this kind of a scenario, they usually don't really biopsy them right away. We usually kind of follow them closely in the clinic and see how they do. Usually it's self-limiting. Patients who do have a persistent proteinuria or decline in their renal function, we actually put them on an ACE inhibitor or combine with the ACE with, you can say, fish oil if you like, if they're able to tolerate. And we usually try to strive for a goal of a protein less than 1 gram per day, and we try to target their blood pressure down to 130 over 80. And if we're not able to achieve that, with just ACE and fish oil combination, and if they're still having persistent proteinuria and they're still having significant renal dysfunction, then actually we actually give them a trial of the steroid therapy on those patients. So steroids are something that we do consider, especially for the patients who are not really responding to ACE inhibitors, for example. And the patients that we use cyclophosphamide, for example, are the ones that have the crescentic pattern that I was describing. So it really kind of depends on how the clinical presentation is, and that's how we kind of approach things. So the milder ones, we kind of see and watch them, and usually they're self-limiting. So those patients do really well. These guys, they kind of have this persistence of proteinuria. We put them on ACE inhibitors and see how they do and so forth, and we try to target this. Then we put them on ACE inhibitor. If they don't resolve, if we're not able to achieve their protein less than 1 gram, we put them on a steroid therapy. The ones with the crescentic pattern, usually these patients are in the hospital setting anyway, so these guys are in the hospital, so these are the ones that we treat aggressively with cyclophosphamide and so forth. And that's it. Do you guys have any other questions? Or go ahead.
Does Schönlein ever progress to renal disease?
Yeah, like you know, some of them don't. Some of them just has this vasculitis pattern, and they don't have any renal involvement. But the ones that have shown renal involvement is the same, it's exact pathology that they've noticed as IgA. So we're thinking it's you know, it's the same variant, you can say, of the disease. But not all the patients who have HELONG have, you know, a renal failure, for example. Some of them just have this really bad vasculitis. You just treat that, and they do well. Not necessarily involving the kidney, but some of them actually, the ones that are, I would say, the sicker ones do involve the kidney, and they have the IgA nephropathy on top of it. Along with the vasculitis that you have to deal with, you also have to deal with the renal failure and everything else. So those are more sicker patients. Yeah, go ahead.
Is there any association with serum IgA levels, and do those levels fall when you immunosuppress them?
That's what I was saying earlier, that I mean, in Japan, they have actually looked at these serum IgA levels. They have this IgA to C3 ratio that they've looked at serologically. But that was just a ratio. But actually, in terms of, we don't really, when we're managing these patients, we don't really routinely, even after we treat them, we don't really routinely measure their IgA levels. So this hasn't really panned out. There's not a good correlation in terms of response, if you mean.
So yeah, that's what I was wondering.
Yeah.
Those who respond, do they have a fall?
No, it's kind of I think it's pretty variable in terms of the, but they have looked at that, but it hasn't really, it would be nice to follow that, but we routinely don't. We just kind of go with the clinical picture, mainly.
Haven't they had outbreaks of IgA nephropathy?
Have they had outbreaks?
Like clusters?
Clusters, I think they, like I said, you know, they have these, you know, people who develop these upper respiratory infections, and they have this hematuria and so forth. That they haven't. I wouldn't say there's. Usually, they haven't really found clusters. I mean, usually it's more of a genetic predisposition, and more, I would say, patients who have this certain geographical areas are more prone to it. But it's not like the epidemic that happens in certain areas. No, we don't see that happening. We kind of think about these things when we look at patients. Like, for example, I was telling you in the U.S., if you go to New Mexico, you have the more Native Americans there. They're more predisposed to it. So we kind of look at it from that perspective. But there's no pockets of IgA that pop up, you know, for example. Even here in Louisiana, we do see it, obviously, but it's not like one of the most common things that we see. So it kind of really depends on where you are.
What dose of fish oil was used?
They were using pretty high doses. I think, I can't really recall exactly, but they were pretty high. And a lot of times, the patients that we've actually seen in the clinic, when we put them on these, I would say, super duper, you can say, doses of the fish oil, they don't really tolerate it well. They have a bad breath, and they smell really bad and so forth. So the patients are very hesitant about keeping. If you even prescribe it to them, they don't really take it because of the smell. If they're able to tolerate it, that's great. But that's why we do recommend fish oil, but it just really depends on the patient. And if they're able to tolerate it, that's great. If not, I'm not really sure about the exact dose, what they give, but it's a pretty high dose. And you can actually give that as a prescription. Any other questions? So still, I would say, in terms of the, I think the pathophysiology is very interesting. Hopefully they can, and the biomarker that's coming out, that's going to be exciting. I think we're looking at biomarkers to kind of help us detect these things earlier. I think that'll be a plus point for us. Anything that we can use to kind of detect these patients early, that'll be a lot of times it's just an incidental finding. They're just seeing their primary care doctor. They just do the primary care doctor does a simple UA, and they find hematuria, and that's how they come to us, basically. Okay. Thank you.